Welcome! Today, we're doing a deep dive into ventilator-associated pneumonia, or VAP. Now, this is a really big deal in critical care. It's a lung infection that unfortunately targets the patients who are already the most vulnerable. Understanding VAP isn't just academic. It's absolutely essential for improving outcomes in the ICU. So let's get into it.
So here's our roadmap. We're going to start by understanding the VAP challenge itself. Then we'll talk about how we identify the microbial invaders, the strategies we use to fight back, and, crucially, how we can prevent it from happening. We'll also cover the high stakes of what happens when VAP does develop, and we'll finish up with a quick knowledge check to make sure it all sticks.
All right, first things first. What exactly is VAP? Let's get a clear definition on the table and talk about who is really in the danger zone for this infection.
So at its heart, VAP is a nosocomial infection, meaning it's acquired in the hospital. The real defining feature, though, is its link to a mechanical ventilator. If a patient develops pneumonia after being on a ventilator for at least 48 hours, we call it VAP. You see, that breathing tube, as life-saving as it is, can also become a direct highway for bacteria to march straight into the lung.
But here's the thing. The risk isn't the same for everyone. It's not a level playing field. Certain patients are far more susceptible. Think about neonates and the elderly. Their immune systems just aren't as robust. The same is true for anyone who's immunocompromised or patients who already have underlying lung conditions like COPD or cystic fibrosis. And it's pretty intuitive. The longer you're in the hospital on that ventilator, the more your risk climbs.
Okay, so you suspect VAP. How do you figure out who the enemy is? You can't fight what you can't see, which is why diagnosis and getting a detailed profile of the pathogen are just, well, they're everything.
The diagnostic workflow is pretty methodical. It all starts with getting a good sample, ideally from deep inside the lungs. A procedure called a bronchoalveolar lavage, or BAL, is great for this. From there, the lab does a quick gram stain. This gives us our first big clue. Is it gram-positive or gram-negative? Finally, for the definitive answer, we either grow the organism in a culture or use faster molecular tests like PCR. That's what tells us exactly what we're up against.
Which, brings us to a little bit of lab humor. I know, it's a groaner, but it actually highlights how fundamental that gram stain is. It's a quick, classic technique that gives us that first crucial piece of information about the bug's cell wall, guiding our very next steps.
So who are the usual suspects we find? Well, it's often a familiar cast of characters. Staphylococcus aureus is a huge one, leading the pack at around 17% of cases that progress to sepsis. Right on its heels are the Enterobacteriales family and the notoriously tough Pseudomonas aeruginosa.
And this is so important. We're not just fighting bacteria, we're fighting their defense mechanisms. Is that Staph aureus a methicillin-resistant version, or MRSA? Is that Pseudomonas already resistant to multiple drugs? Are we dealing with Enterobacteriales that produce enzymes like ESPLs, which chew up our common antibiotics? These questions about resistance are what truly define the modern challenge of treating VAP.
Which leads us straight into our counterattack. Once you know your enemy, you can pick your weapon. And the strategy really changes depending on whether you're treating an adult or a child. For an adult with severe VAP, every minute counts. We can't afford to wait for those culture results to come back. So we start with what's called empiric therapy, basically our best educated guess. A very common strategy is to hit the infection hard with a combination of drugs, like a cephalosporin plus ciprofloxacin, to cover all the most likely bases right from the get-go. But then, once the lab calls with the specific bug and what it's susceptible to, we pivot. This is called de-escalation, and it's a cornerstone of good antimicrobial stewardship. We switch from that broad shotgun approach to a targeted rifle shot. If it's a simple MSSA, we use flucloxacillin. If it's the dreaded MRSA, we bring out the vancomycin. This kind of precision is what wins the fight while minimizing resistance.
Now, in the pediatric world, the playbook is totally different. For a tiny neonate, under 2 months old, the go-to empiric combo is vancomycin plus ceftazidime to cover the bugs common in that specific age group. For older kids, the regimen is different. And the absolute golden rule here is that dosing is never, ever one-size-fits-all. You must always refer to specialized pediatric formularies.
The best kind of fight is the one you never have to have. So let's talk about being proactive. Let's talk about prevention and control, how we can actually fortify our defenses to stop VAP before it even starts.
Prevention really stands on two legs. The first is universal and foundational, just really rigorous hospital hygiene. We're talking obsessive hand washing, meticulous disinfection of equipment, the basics done perfectly. The second leg is more targeted. For certain high-risk patients, we can use a strategy called selective digestive decontamination, or SDD. This involves giving prophylactic oral antibiotics to suppress bad bacteria in the digestive tract before they have a chance to migrate to the lungs.
And if an infection does take hold, containment is everything. That means strict isolation protocols are non-negotiable. For many BAP pathogens, this means contact droplet isolation. For something like tuberculosis, it's full airborne isolation. And anytime a procedure that generates aerosols is performed, FFP2 masks are absolutely mandatory to protect the entire healthcare team. So why all this fuss? Let's take a hard look at the consequences of VAP. Understanding the potential complications really drives home why this is such a critical battle to win.
The fallout from VAP can be devastating. It can spiral into acute respiratory distress syndrome, ARDS, or a body-wide infection leading to sepsis and septic shock. It can cause localized damage, like fluid buildup in the chest or even lung abscesses. It significantly increases the risk of mortality. And even for those who survive, the story isn't over. Many face long-term problems, like cognitive deficits and a higher risk of future cardiovascular trouble.
Okay, we've covered a lot of ground. Let's do a quick check to help all this key information settle in. Okay, for our first question, think back to the lab clues. You have that classic appearance on the gram stain, and you're in a high-risk VAP setting. What's your move?
The answer is vancomycin. Gram-positive cocci in clusters is the textbook description of Staphylococcus. And in a hospital environment where MRSA is a constant threat, you have to cover for it empirically. So, you start vancomycin while you wait for those final culture results.
All right, question 2. Let's shift our focus to the tiniest, most fragile patients. What was that specific 2-drug combination we talked about for an infant under 2 months old?
That's it exactly. Vancomycin and ceftazidime. That combination gives you that really broad coverage you need against the whole spectrum of bugs that pose a threat to this very specific high-risk group, from resistant gram-positives to tough gram-negatives.
And that leaves us with this final, critical thought. The fight against VAP is not a static one. It's a dynamic arms race. The pathogens we face today are constantly evolving, constantly finding new ways to outsmart our best drugs. So the question we always have to be asking ourselves is this: how do we make sure our playbook, our diagnostics, our treatments, our prevention is evolving even faster? It's a challenge that demands constant innovation and vigilance to stay ahead.